Hi, I'm Bob Redner, and my
And I'm Jakub
colleague,
Svoboda.
and we're happy to take any questions on the heme malignancy portion of today's sessions.
We don't see you guys, so but we can see your questions when they come through. So we encourage you to ask as many questions about the presentations from today or general questions about some of the updates in heme malignancies. I focus mostly on lymphoma in my practice, so any leukemia question will go to Dr. Redner, but please don't hesitate to ask.
Please type them into the chat box. Well, while we're waiting, I'll ask a question. In terms of mantle cell lymphoma, there are a number of different options for upfront treatment these days. What do you prefer to use?
So that question actually just happened to me this past week. I saw a patient, 48-year-old gentleman who had fairly high white blood cell count, lymphadenopathy, and so initially when I kind of reviewed his case, kind of on the surface before I even got to see him, I thought, well, I'm probably going to use one of the standard treatments, which includes several, as you mentioned, but the one that I was going to use was R-CHOP alternating with RDHAP, followed by autologous stem cell transplant. And again, this regimen has a really high, response rate, very high duration of response in majority of patients, and tends to be pretty well tolerated in a 40, 80-year-old. Obviously, there's some implications in terms of immunosuppression and some possible damage to stem cells and potential for secondary MDS, but I think it's a well-tolerated regimen. But this particular patient had, when we looked in more depth in his pathology, he had p53 deletion in 80% of his cells from the biopsy of the lymph nodes, and so that completely changed my thought about him. Looking at some of the PFS curves in patients with these p53 either deletions or mutations in mantle cell, and so we actually offered him BTK inhibitor in frontline. So it's not necessarily perfectly according to the NCCN guidelines when you look at that, but I think these days we can make some decisions based on our own experiences. And in my experience, the patients with these, similar to other malignancies, specifically CLL, they just don't do very well with standard chemoimmunotherapy. And so some of those. So I think that to answer your question, is it really, it's a good news for us, but it gets more complicated, is that we do have more options than just one. So you really have to tailor the treatment. It's not wrong to use R-bendamustine, but again, that's a pretty immunosuppressive regimen. We did see the presentation at this year's ASCO from Dr. Mitchell-Smith, who presented the data on adding Velcade to the BR, and unfortunately in that large trial it didn't show any benefit. So it doesn't seem that adding bortezomib to the BR in those patients adds much at all. This particular study actually that was presented also is going to produce some data on maintenance, R-square maintenance versus Rituxan maintenance. So we're still awaiting those results. But that field continues to evolve. We may, kind of like in CLL in the future, we may see combination of different novel agents, BTK inhibitors. So there's many options, and really my decisions depend on particular situation. And I think that this is similar to CLL, a disease where we will start to look at the more in-depth biology of the disease, because it's a heterogeneous disease.
I see that there are a few questions that came through on CLL and lymphoma.
Okay, I see one from that I guess would come to me, and marginal zone lymphoma with humongous splenomegaly, no improvement with bendaritaxan ×4 with severe anemia. Do you recommend splenectomy or trial of ibrutinib? Again, it's a great question. You know, the one thing I would consider in that case is, while I don't always do PET CTs in indolent lymphomas, especially, you know, some of these asymptomatic lymphomas, in somebody like that, I may consider doing a PET CT. The reason is that if there's a really high SUV uptake, FDG uptake and high SUV in the spleen, I may be worried that the patient transformed in the spleen, and for that, sometimes just trying to document transformation by splenectomy is what we've done. If there's no sense of more aggressive pathology, I probably would use a BTK inhibitor like ibrutinib in marginal zone lymphoma. We've also seen some other novel agents that have been approved, like umbralisib for marginal zone lymphoma, which, you know, compared to some of the other PI3 kinase inhibitors, like adalasib, seems to have perhaps better toxicity profile. So I think that, again, you probably would need to know more details about this patient, but both of your thoughts are, you know, very reasonable, but again, may depend on how much I'm worried about transformation.
And I see another question regarding the ibrutinib study is, what is your preferred regimen for first-line CLL with a p53 mutation?
So I probably should replay the response to the, you know, to the mantle cell question, because these days, and I think that in any disease in oncology, people start to appreciate it. It's very hard to say there's one, you know, one answer, what's the best first regimen, right? So again, CLL is a very, very heterogeneous disease. You know, the whole decision about the 17p deletion, again, I just mentioned it in mantle cell, but in CLL used to be a major determinant of chemo like FCR versus ibrutinib. And when you look at the old NCCN guidelines, you know, the front line actually allowed you to use ibrutinib in 17p deletion patients even before you know, these days you can obviously use it in frontline for anyone. But it was recognized early on that the 17p patients did worse. But these days, it's not as much of a player for me to choose therapy. So I would answer that the 17p deletion doesn't play as much of a role for me, like what agent I decide. You know, they're definitely, I don't use chemotherapy for those patients. So the decisions are, should you use sort of the defined regimen like obinutuzumab plus venetoclax, which was, you know, the CLL14 study that showed really nice results in patients, whether they had 17p deletion or not. And then, you know, or one of the BTK inhibitors. So we heard about the acalabrutinib versus ibrutinib study, the Elevate trial, which actually did include 17p deletion and 11q type of patients. So we, you know, we have data from that. And again, so I think that my decision these days is based on a few things. In the era of pandemic, I do feel that starting BTK inhibitor is perhaps easier. You don't have to deal with that, you know, the escalation. Patients don't have to come back and forth. It also appears that, you know, the BTK inhibitors, we've seen a certain amount of cytopenias. So I think in the mid of pandemic, when things were really quite severe and we were very limited in terms of our access to the cancer center and whatnot, we sort of used more of the BTK inhibitor route than the obinutuzumab plus BCL2. But now I think that situation is getting better. It's not perfect for sure, and we know that the CLL patients do not have such a great response to the COVID vaccines. But still, I think that there is definitely interest in patients who like to be treated with a defined regimen like obinutuzumab, venetoclax. But I do think that the future will again be changing fairly soon. With we've heard a little bit of data on Captivate, which is the combination of ibrutinib plus venetoclax, for just a couple of years, and again that looks very encouraging. We're getting a new drug hopefully approved pretty soon, Loxo, which is a BTK inhibitor that seems to work a little bit differently than the traditional BTK inhibitors. And so a lot of things are going to be changing in the next year or two. So again, I think that it really depends on a lot of factors.
I just want to remind the audience that the ibrutinib trial that you highlighted was focused on relapsed refractory patients, not upfront use in CLL.
So since we talked a lot about the lymphoma CLL up to now, I do want to also focus us a little bit on some of the leukemia. So the CML field seems very, again, rich in new therapies and new agents. So I was going to ask Dr. Redner, I don't treat CML very much unless I'm on inpatient service, which is very rare to see the CML patients there. But I do, I'm interested in some of the novel agents. And, I know that you talk about ponatinib in your ASCO review. Can you just tell me, like, what it used to be Gleevec for everyone, right? And then it started to be a little bit more complex. And and that's where I haven't been following the literature, but can you just tell me what do you use these days as a front line for CML, and what factors in your decisions?
There are primarily 5 different tyrosine kinase inhibitors that are on the market these days. There's Gleevec, nilotinib, dasatinib, bosutinib, and ponatinib. Ponatinib is not approved for first-line therapy. The other 4 are. Gleevec has the advantage of being the first and now having a 20-year track record. So there's a lot more experience worldwide with its use and with potential toxicities. All of them have, to some degree, toxicity of veno-occlusive disease, similar to ponatinib, though ponatinib seems to have a much higher incidence. Dasatinib has as a side effect pulmonary hypertension and pleural effusions. So I usually avoid dasatinib in somebody who has pulmonary disease. Nilotinib can exacerbate hyperglycemia, and in some patients, and I've had one patient with this, lead to pancreatitis. So I usually avoid nilotinib in patients with diabetes. Bosutinib has, as an expected side effect, diarrhea, though usually it wanes within the first few weeks of therapy. The 3 second-generation therapies, nilotinib, dasatinib, and bosutinib, all have been shown to achieve deeper remissions and faster remissions than Gleevec, though none of these translate into survival advantage. So I still use Gleevec. For it's suggested that patients with high Sokal scores go straight to one of the second generation therapies because it's been shown that those folks have better responses than Gleevec. But for first comers, I think there's any of those four are good choices. I usually reserve ponatinib because of the concern of the veno-occlusive disease and arterial occlusive diseases to third-line therapy, or in some patients, fourth-line or fifth-line therapy, if I've exhausted all the other options. Ponatinib works very well. I usually do start patients on a baby aspirin, and I usually try to mitigate any factors that could impact arterial occlusive disease, such as hypertension, hyperlipidemia beforehand. But it still is a very active agent. Some folks think that it's the most active of all five.
With the CML, it always seemed, the care is getting more and more complex when you're looking at the changes in the log, when you're looking at the different submutations of the 922. I always felt that it's again, as a field, it's very different than 15 years ago.
Yes, the ponatinib is active in the T315I mutation, whereas the other four are not. Soon, I believe, will be yet another agent on the market, axitinib, which is an inhibitor that does not interact with the ATP binding site. So it should be active, and preliminary results suggest it is active in folks who have failed all of the other agents. And I think many of us in the CML field are looking forward to FDA review, which I believe is ongoing as we speak.
Great. Well, it looks we're almost out of time. This has been a challenging year for research, but I think that this ASCO showed that we persist and we continue to sort of push the knowledge and continue to improve the care of the leukemia, lymphoma, myeloma patients. And so I think it was an exciting ASCO, at least for me. There was many abstracts that I couldn't mention, but thank you for your attention. Please do not hesitate to contact us if you have any other questions throughout the conference. And again, we would like to also thank the organizers for having us and the exhibitors who contribute to make this ASCO review possible. And if you do have time, please check out with them. They may have more information on some of the products that we mentioned today. And again, I hope you have a great rest of your conference, and thanks everyone for your attention.
And stay safe.